Well, good evening, everybody. My name is Mark Monahan from AquaCast, and I'd like to thank you for joining us for our webinar, How to Reduce Cast Complications and Increase Patient Safety. Our featured speaker is Dr. Julie Samora from Nationwide Children's Hospital in Columbus, Ohio. Dr. Samora received her orthopedic training at The Ohio State University and completed a fellowship in hand and upper extremity at Harvard. She earned a Bachelor of Fine Arts at Carnegie Mellon, a Master's of Music at Yale, and her MD and PhD at West Virginia University, where she also acquired multiple master's degrees. She has a passion to provide safe, efficient, and excellent patient care, focusing on best practices and quality improvement initiatives as the Director of Orthopedic Quality at Nationwide Children's. We're thankful for her joining us as well as you on a busy Wednesday evening. And we also invite you to stick around for a special offer at the conclusion of the presentation. And now I'll turn it over to Dr. Samora.
Thanks, Mark, for that introduction. Thank you all for joining us this evening to discuss how to reduce cast complications and increase patient safety. I have no disclosures relevant to this talk. The objectives for this evening are to identify the most common cast complications, particularly in a pediatric setting, to acquire tools to decrease harm from cast immobilization, and to recognize the benefits and safety of using waterproof casts. We frequently use casts as routine treatment for not only traumatic injuries, but many musculoskeletal pathologies, particularly in pediatric orthopedics. Casts can be applied and removed by trainees, such as medical students, residents, and fellows, physician extenders, such as nurse practitioners and PAs, as well as attending surgeons and cast technicians. Casts are not benign, however. There can be complications which occur during the application of casts, throughout the immobilization process, and during the removal of casts. These complications include cast saw injuries, deformity, compartment syndrome, skin injuries such as pressure sores, as you can see here, and rashes, and burns. As important as the clinical implications are, cast complications also have medical, legal, and financial ramifications. These data are a little bit outdated, but Holansky and Noonan published in 2008 that insurers paid in excess of $100,000 per claim for about a third of medical malpractice claims related to closed fracture management. Causes and incidence of these complications vary significantly. Improperly or irregularly applied padding may result in pressure sores. If you don't have enough padding, this can lead to sharp edges and skin irritation and even cuts to the skin. If you have an aggressive mold, it can cause pressure sores or even lead to compartment syndrome. And even if you use a little bit too warm of water to activate the casting material, it contributes to thermal burn injury. Sometimes there are patient factors which can increase injury as well. If you look at the clinical picture on the top right, you can appreciate how much swelling there is. When we need to bivalve a cast due to significant swelling, that places the skin at higher risk as well. You'll also note on this picture here that there is no protective strip. The incidence of cast complications is not well known. We know that in children treated with hip spica casts, skin complications can occur anywhere from 15% of the time to 38% of the time. In a large pediatric institution, it's been reported that cast saw injuries can occur at a rate of 1 per 1,000 cast removals, or about 0.12%. And in an adult fracture clinical setting, it's been reported that cast saw cuts or burns can occur at about a rate of 0.72%. This sounds like a really low rate, but when you're applying thousands and thousands of casts every year, that actually adds up. In our freestanding tertiary care urban pediatric hospital, we apply more than 9,000 casts each year. When we were first looking into our cast complications, we had roughly almost 6 complications per 1,000 casts applied, a rate of about 0.56%. Most of these injuries were pressure ulcers and cast saw burns. This is an example of an extremely severe cast saw burn. Just imagine if this were your child. Here's another example of a cast saw injury, discovered when the final cast was removed. We considered this rate of iatrogenic injury unacceptable and excessive to our vulnerable, young patient population. We therefore implemented a quality improvement project using the IHI model and implementing PDSAs, or Plan, Do, Study, Act cycles, to decrease our cast complication rate. Our specific aim was to decrease the number of cast complications in casts applied to extremities in children presenting to many of the NCH locations from an average of 2 per 1,000 to 1 per 1,000 by the time we started this project. Now this slide is very busy and I'm not going to go into detail, but essentially this is our key driver diagram. And in that center column are the key drivers that we thought were critical to improving our cast complication rate. This included education, equipment supplies, as well as policy and procedures. And I'll review some of the interventions that we implemented. So the first step in any quality improvement project is to really obtain buy-in from all key stakeholders. In our case, we needed to obtain buy-in from attending surgeons, the cast tech team, the residency program director and coordinator, and the APP lead. We gathered information on the root of the problem, trying to figure out when and where these injuries were occurring. And then we worked with many folks to develop a cast competency form, which went through several revisions, which I'll talk about later. What we found was that we were actually under-documenting these injuries. So without reporting, we would never know what our baseline rate was and whether or not we were improving. So we really routinely recommended everyone document, document, document. This is a Pareto chart, and this is done when you're trying to figure out what type of complications you're dealing with. And we found that cast saw injuries and pressure ulcers were our two biggest categories of injury. To give you some background on our hospital, we support 3 separate orthopedic residency programs, including 2 allopathic programs and 1 osteopathic program. And residents rotate anywhere from 1 month at a time to 6 months at a time. And some of them have just graduated medical school and some are chief residents. So they really come with a range of experience. A critical intervention was the development of a resident casting education program to develop and improve the skill set of each resident. This promoted not only observation, but also hands-on skill enhancement. You can see pictured here one of our residents placing a cast under observation. The education sessions were conducted at the beginning of each rotation for each resident. Residents first received some instructions on the differences between plaster and fiberglass casts, how to apply a cast, how to safely remove the cast using a cast saw, simply by observation. Then it was their turn. Residents then practiced these techniques, applying and removing both short arm and long arm casts under direct supervision. A competency checklist was developed and utilized to ensure that casts were being applied, bivalved, and removed in a safe and standardized measure to prevent patient harm. We also require the use of cast safety strips for each cast applied. These shielding strips provide an extra layer of protection between the skin and a cutting blade of the cast saw. Stork and colleagues had demonstrated the efficacy of the safety strip in reducing simulated contacts with an oscillating cast saw during cast splitting. So what are these strips? Well, here is the 2 options that are available. The blue strip on the left was the first strip developed, and the white strip on the right is the most recent strip that's developed. The blue is tough and waterproof and very flexible. The white is heavier, but actually thinner. We continue to use the blue strip because it's cheaper than the newer white strip. So these strips are applied in the area where you expect to be removing the cast. You first place the liner, whether it's a waterproof liner or a cotton liner, which here's pictured some waterproof liners. Over top the liner, you then place the deflex strip. Over top of that is then the fiberglass material. If you're placing a short leg or a long arm cast, as visualized here, you need to have two separate strips to meet up with that 90-degree angle. So here you can visualize where the strip is immediately underneath where the cast saw has made its cut. You can see how that provides an extra layer of protection. In our didactic session, we also demonstrated proper cast saw technique. Key risk factors for cast saw injury include provider inexperience, patient sedation, and poor condition of the cast saw blade. Iatrogenic injuries such as burns and abrasions occur from the heat created by frictional forces as well as direct blade contact with the skin. Reusing a saw blade even a few times can increase those blade temperatures by 20 to 40 degrees. Our educational initiative focused on teaching proper technique, and we emphasized having a heightened awareness for cast saw burns that can happen in patients who are nonverbal, comatose, anesthetized, or sedated, as routinely happens when we're performing reductions in the emergency department. We also ensured that cast saw blades were in good working order in all sites. Because we have multiple locations, each site developed its own mechanism and personnel responsible. We spent time demonstrating the best method to utilize the cast saw. This requires an up-down motion, ensuring complete penetration through the fiberglass before moving to the next section. We highlight that you cannot simply keep the cast saw blade down throughout the length of the cast cut. We also recommend that the trainees evaluate the heat of the blade with their fingertips. If it's quite hot, take a break or use a cool cloth to cool it down. The second picture also demonstrates the technique of using an alternative part of the blade if the center region becomes dull. A dull blade will lead to increased heat production. Competency was measured and recorded using the criteria outlined here in the performance assessment form. Residents were required to demonstrate competency with 3 cast applications and 3 removals before they were permitted to apply or remove casts independently. We did not teach this routinely as part of the didactics, but a zip stick can be used to provide another barrier to the skin. It's a great option for even greater protection. Sometimes you cannot actually get the zip stick underneath the cast because it's too tight, but if you can use it, this is a great option. We ensured adequate inventory of cast safety strips and cast saws. We also required daily audits and blade checks to be performed at each location. This figure demonstrates a significant reduction in both cast saw burns as well as pressure ulcers. This is a combination of efforts, including the didactics, the policy changes, and use of the safety strips. For those of you who may not be familiar with some of the run charts as used in IHI methodology, this is a U chart used for infrequent events, demonstrating a baseline rate before we started anything of about just under 6 IMP complications per 1,000 applications. You can see by the beginning of 2016 to the middle part of 2016, we reached a new low. This quality improvement project did result in a 97% reduction in cast complications. We went from nearly 6 complications per 1,000 casts applied to about 0.15%. It's hard to know which intervention led to the majority of the improvement. I think the education was critical, but I also think the deflex strips played a tremendous role in decreasing complications. To give you some background on these protective strips, they were invented by Gore in the early 1990s, to prevent injuries when cutting through their thin waterproof padding. We apply these deflex strips routinely to short and long arm casts, as well as short and long leg casts, regardless of whether we use a cotton or a waterproof liner. They can also be used on Spica and Metacasts. I wanted to take a moment to discuss the use of the waterproof liner, as I have been surprised to hear that other pediatric orthopedic surgeons sometimes have never tried this material and may even have concerns about its safety. We routinely use the waterproof liner in our clinics. Our patients are thrilled when they get to transition from the traditional cotton-based padding, which was applied in the ED or urgent care, which is non-waterproof, to the waterproof liner. We even have patients who drive from several hours away just to get the waterproof cast, particularly in summertime. In the days of COVID-19, it adds the additional benefit of permitting routine hand washing. The skin also generally looks quite good when the cast comes off at the end of treatment. One of our surgeons at Nationwide routinely uses the waterproof liner for hip spica casts, and his families are really excited to have this option, particularly for this body cast. This same surgeon also uses the waterproof lining for his metacasting. These images are courtesy of Dr. Reed Chambers. You can appreciate how much easier hygiene would be for the waterproof body cast. In conclusion, cast complications create an economic burden for patients, hospitals, and insurers, and cause significant patient harm. There are methods that can help minimize cast complications, such as utilizing good techniques and protective strips. And finally, waterproof casts are safe and do enhance patient and family satisfaction. Thank you for the opportunity to discuss this topic, and I'm happy to answer questions.
Yeah, thank you, Dr. Samora. Excellent presentation. And before we move into the Q&A portion of the presentation, we'd like to invite you to experience the benefits of SawSop deflex strips and other products from AquaCast. For those facilities which have not used any of these, we will provide you with a complimentary starter kit. For those which have used the product, we're excited to offer a new promotional day concept. And to learn more about either one of these, please email us at the address on the screen or send your contact information in the chat box in Zoom or contact your local representative. And we'll now open this up for some of the questions. And it looks like we've gotten a bunch already. So Dr. Samora, the first one, can you use the SawStop on regular cotton padding or other synthetic materials?
Yes, so the protective strip is ideal for really every cast, regardless of what the liner is. Again, it was developed for the thinner waterproof material, but we also use it on the traditional cotton because, again, our goal is to prevent the actual cast saw from touching the skin.
Okay. Here's a question from a provider in Florida. Let's see. Can the deflex strip negatively affect the molding of a cast?
Oh, good question. So our residents are required to put this on for every reduction they do in the ED, and they're doing some pretty aggressive molds when they're putting on the casts. And this is soft and flexible, so no, it does not get in the way of any mold.
Okay, terrific. We've actually heard from a number of facilities that actually use it on their club feet casts, even with plaster, just to prevent nicking the baby. So they typically use the white because it is a little bit more conformable. All right, and kind of a similar question looks like around SawStop or deflex. Has this product been around long or tested in other facilities that you are aware of?
Mark, you'll have to help me out with that answer.
Okay. Well, I know Gore had invented the product in the early 90s to prevent cast all injuries and the use of their waterproof liners. And we've been making it since 2012. So it's been around for a long time. Gore had thousands of customers and we have thousands of customers. So, it's been around, and, some of the top pediatric and some of the top orthopedic hospitals and clinics in the country, really across the globe. We have people from all over, including Australia, New Zealand, and Europe and Southeast Asia here as well. Has this product, let me see, excuse me, here's one that switches the gears to the padding, Dr. Samora. It says, you show the waterproof padding on long arm casts. I thought this product couldn't be applied on these.
Yeah, there are some providers that are concerned about using a waterproof liner for long arm and long leg casts. Again, if we have someone coming into our clinic that needs either a long arm or a long leg, we routinely use the waterproof material. There might be some skin irritation at the antecubital fossa because that's where the water takes the longest to dry. But these skin issues that are usually mild resolve in a week or two after the cast is removed. So we do not see it as a contraindication.
Okay, all right, terrific. And are there any other contraindications, just kind of as a follow-up to that?
Yeah, I would say if you notice some severe eczema on your patient, we have seen reactions to the waterproof liner with those that have eczema. So it's a discussion with the family as to whether or not they want to take the risk. And some of the issues we've seen is a skin reaction. They can get really itchy and red. And actually, I've seen some skin sloughing in the most severe cases. So I would say have some reservations about putting this cast liner on someone that you see with open eczematous wounds.
Okay, and then we have one in reference to your competency checklist. How you came? Let me see here. Bear with me.
Yeah, it's can you review your competency checklist and how you came about determining the best way to competency casters?
Yeah, that's a great question, and this is not validated. We have found it to be a pretty good assessment. And really the main point is that we're seeing someone do multiple applications and multiple removals before we let them fly on their own in the emergency department. And so these are sort of the checklist that we thought that needed to happen, is that they had the right stockinette length and width. They have, the appropriate amount of cast padding, their temperature is not too hot, that they know how to put a mold, that the cast length is proper. We have a lot of residents that put the fiberglass way too far on the thumb and beyond the MP joints. And then critically important is that cast saw technique and the use of the deflex tape. And so this went through PDSA cycle after PDSA cycle. We sort of tried it, and then we had some input, and we had some back and forth from not only the technicians and the attendings that were doing the assessments, but also the residents themselves and even the program director. And so this is not a validated checklist, but it's worked for us. And then the question is, why 3? 3 really actually is an arbitrary number. We started with 5, which we ended up realizing that was quite a lot. And so we sort of narrowed it down to 3. 1 is too few, 5 is too many. And so this is kind of like Goldilocks, but this is kind of how we came to arrive at this assessment form.
Terrific. And then we had one just pop up. Can the waterproof liner be used for serial casting?
Oh, sure. Sure. Again, there's no contraindication. I mean, we have casts that have to stay on for several months in some cases, and this works terrifically.
Okay, terrific. Well, we may have time for just one more, and let me see here. What is the difference between the blue and the white deflex strips?
Yeah, Mark, I might have you try to answer that one as well, because we really only have experience with the blue one. Sorry, I'm trying to find that picture so you can see it.
Okay, terrific. Yep.
Where is it? Sorry.
Yeah, both products are waterproof. The blue is the first product we had come out with. The white, as Dr. Samora had mentioned, is a little bit heavier, but it's actually thinner and it's considered more conformable by most of the facilities that use that. It is an ePTFE, which some people will refer to as Gore-Tex. And, typically the white is a little bit more expensive than the blue, but both are excellent products. I'd say probably 90% of the saw stop deflex strips that we sell are the blue variety. But that we're kind of running out of time at this moment. So Dr. Samora, we want to thank you for joining us for this presentation. Excellent job. And for everyone that joined us on this Wednesday evening and Wednesday afternoon, in some cases Thursday mornings, we appreciate you coming to join us. And we'll follow up on any of the unanswered questions, as well as getting everybody a copy of this presentation. But thanks again. Have a great evening, everybody. And we'll follow up on our next webinar in the next month. Thank you.
Great, thanks.